record. So hi everyone. So this would be one of four revision lectures run by MUMUS. Thank you all for coming. Today I'll be covering the respiratory system. We'll be broadly going through all respiratory content, but as I said, more in a question style thing. I would love for this to be as interactive as possible. So if you guys could open your chat and type out the answers to what you think to the questions, just so I know a general idea as to how well you know those questions and whether I should go into more detail when explaining them. And obviously, if you have any questions, let me know. These are the references I've used for this presentation. So let's really just jump into questions. So a supine 80-year-old female inhales some gastric contents into a segmental bronchus. Aspirated material is most likely to enter which lobe of the lung? Now, this is a very typical question you can expect. You will definitely at least get one question on aspiration and lung stuff. If you want, you can just send them in the chat or even just private message them to me. I'm equally happy with both. So I can see that there are 40 people, so I should at least expect a few more answers to come in. And if you're embarrassed to send questions, the answer in the chat, as I said, just private message them to me. This will not be up on the recording later. Yeah, as a lot of you said, the is the correct answer here. So for any gastric content being aspirated, if the person is supine, erect, or on their right, it is more likely to enter the right lung. And this is because of some very distinct differences between the left and the right bronchus. If the person is on the left, someone asked me this, it is more likely to go in the left, but I don't think they'll ask you that. So starting off with anatomy of the lung, this is all stuff you would already know, but I think some broad differences would be the fact that you have to know that the right lung has 3 lobes while the left has 2. And they're slightly different shapes because the left accommodates for the shape of the heart. As far as bronchopulmonary segments are concerned, each lobe is further divided into a few segments. You don't really need to know much about the segments, but I think where they do come into play are in the right lower lobe, when then you may be asked where aspirated stuff might go if a person is supine versus erect. And that would be, again, the basal versus the posterior basal segment and so on. And you also need to know that if there's a local tumor in any of the lobes, it can be resected surgically. So let's talk a bit about bronchi, which is what the question was based on. So the few main differences which predispose the right bronchus to being kind of the source of aspirated food material are the fact that it's shorter than the left. It's also a bit wider, and at a lesser angle, so it's more vertical than the left. So anything that comes down the trachea is much more likely to enter the right than the left. And here's a very typical example of what happens when what goes wrong when that happens. So this is a case of pneumonia, as you can see. You can see that there are kind of diffuse patchy opacities, and it's localized to one region. So there seems to be quite a distinct cutoff zone. So this is very typical of pneumonia and aspirated pneumonia for this case. And as you can see, it's confined to the lower lobe of the right lung. We've already talked about this. If a person is erect, it's more likely to go in the posterior basal segment. Supine superior, and the person's laying on the right side in the posterior segment, all of the right lower lobe, except the laying on the right side, which is the right upper lobe. And here's just a diagram of that. And you can kind of see it makes sense if you imagine a person laying down. Just think of if you dropped a marble, where would it go, kind of thing. Okay, so what's the arrangement of the right lung hilum? So this is the artery, you need to know the artery, vein, and the bronchus and how they're arranged. Okay, so I'm getting quite a few mixed answers for this one. So the answer is actually B. Um, a really easy acronym you can use for this is RALS. So it's talking about the position of the pulmonary artery in relation to the main bronchus. Okay, so if you look at this diagram, the bronchus is always kind of posterior. The position of the pulmonary artery is one which varies the most. So, and it's relation to the main bronchus. So in the right lung, it's anterior to the main bronchus, and in the left lung, it's superior to the main bronchus. The blue one is the pulmonary artery. It is blue because it contains deoxygenated blood because it's a pulmonary artery. I think you guys should know that. Yeah, this is again a very typical question, which I would hate for you guys to lose marks on because it's really easy to get with this acronym. And the bronchus is always posterior. The vein is always inferior. Um, where should a chest tube be inserted? So this can be for a pneumothorax, for a consolidation. Um, if you were to put in a chest tube, which space and which location would it be put in? Perfect. So the answer is the fifth intercostal space in mid-axillary line. I think everyone got that one. Um, the reason it's not the second intercostal space is because you perform a needle decompression of a tension pneumothorax at the second intercostal space, but you don't actually put in a chest tube. It's actually at the fifth intercostal space where you put in the chest tube for something like a pneumothorax. The relationship between the visceral and the parietal pleura. So this is something which I never thought was of much importance until the exam, and then we got 6 questions on these, and I lost 6 marks on this. So I think this is really important. Um, it's basically talking about lines of reflection, which I didn't understand much of, but what it basically means is that there exist differences between the area covered by the visceral and the parietal pleura. These areas are often vulnerable sites in cases of stuff like injuries, and also important for procedural stuff, so chest tube insertion and so on. Um, you need to know, so basically the rib numbers just basically mean to what point do they extend in the midclavicular, mid-axillary, and mid-sternal um, lines. So lungs would obviously be the visceral pleura. So if I were to say rib 6 for MCL, it would mean that the visceral pleura extends to rib 6 in the midclavicular line. Okay, and a really good way to remember this is 6, 8, 10 plus 2. So it's 6, 8, 10 as we go laterally, and the parietal pleura is just 2 down for each. So it's 6, 8, 8, 10, 10, 12. Yeah. I think it's pretty self-explanatory. Very briefly, some chest wall deformities. So you cover this broadly in clinical skills that the patient has no observable chest wall deformities, but a lot of you probably don't even know what you're looking for, which is perfectly fine. The two most common ones that you'd expect would be barrel chest and pectum excavatum. Barrel chest is when you have kind of an increase in your thoracic ratio, and this is very typical of someone who might have COPD, secondary to smoking, for example. And then pectum excavatum is when you actually have an incaving of your sternum, as you can see here. It's almost as if you're digging in. That's why it's called excavatum. And it's also associated more commonly in children who are suffering from acute respiratory distress. So because they can't actually breathe in stuff, this might be anaphylaxis or just their throats closed. But they have a bunch of negative pressure, but the air is not coming in, so their chest just caves in. Stuff like scoliosis and kyphosis, it's just important to know that these would cause kind of a restrictive um, pathology pattern on spirometry. Okay, so which of the following conditions is most likely to be associated with a friction rub on auscultation? So asthma, COPD, pneumothorax, pleurisy, or a pneumothorax? Yep, perfect. So the answer is pleurisy. Do you guys know what pleurisy is, or was just the most plausible answer? For a few, yeah. So someone said pleural effusion, but it's similar. It's basically inflammation of the pleuras, which can be because of a range of causes. So a friction rub basically means that the two layers are rubbing against each other. If you remember, they shouldn't really be touching each other. They should be slightly apart. But if they're inflamed because of something like a pneumonia, empyema, or so on, it can actually cause pleurisy. So very briefly talking about the two pleuras, there are two of them. There does exist a potential space between them. There should not be any fluid in them. In case there is, that would be a pleural effusion. You also need to know that the visceral pleura is innervated by visceral nerves, while the parietal pleura has somatic innervation. This means that the parietal pleura can be subjected to very acute, sharp stress pain patterns, while the pain pattern of the visceral pleura is more general and can often be referred as well. So with infections, you get something called pleuritis, which is also called pleurisy. And then you can also have damage causing a collapsed lung, pneumothorax, hemothorax, hydrothorax, and so on. As far as lymphatic drainage is concerned, you can go on to memorize this pattern from the superficial to bronchopulmonary, inferior tracheobronchial. But what I'd say is just focus on the important ones. So the hilar ones are really important. So the inferior tracheobronchial are probably the most important ones. These are the carinal ones. A very common question you might get is someone on bronchoscopy has a blunted kind of bronchial angle. What does this mean? So blunted bronchial angle just means that there is something which has infiltrated these lymph nodes, causing the angle to not be as sharp. This can be either a malignancy, this can be an infection, but it's definitely something worth investigating further. The transverse thoracic plane, it's not really as important for clinical stuff, but it's just important as an anatomy question. You can just get which of the following is present at the transverse thoracic plane level. If I know the anatomy department, they probably will do that. I mean, there's nothing stopping them. But yeah, if you do get the question, there's no way you can get yourself out of it unless you know what stuff runs there. So I just say memorize it. Important ones I'd say are bifurcation of the trachea, arch of the aorta, and the second costal cartilage, because that's how you identify it. So let's talk a bit about physiology. So the mechanism of breathing, there exists a negative pressure between the two layers of the lungs. This is the intrapleural pressure, which is negative. You also need to know that the lungs have an internal elastic force because they're quite spongy and they have a tendency to just collapse on themselves. And it's just this equilibrium which is preventing that from happening. And you need to know that when you do breathe in, you have a decrease in your intrathoracic pressure. This causes air to rush in and vice versa for when you breathe out. I think that's very basic. As far as these numbers are concerned, 760 mmHg is just your atmospheric pressure. You need to know that there is a difference of about 4 between the two. So the intrapleural pressure, or the pressure holding your lung back, almost in this suction kind of thing, is 4 less than your atmospheric pressure, while your lungs have a collapsing force about 4. So they kind of balance out. How do these pressures change during inspiration and expiration? There is a slight change when this happens. I think from your perspective, all you need to know is that the intrapleural pressure decreases a bit more than the intrapulmonary pressure, and that's just to account for the extra stretch. I did talk a bit about the depth of how this happens, but I don't think that's important as much for exams. Internal forces within the lungs. So this is something which they often might ask, and you need to know that surface tension and surfactant contribute to about 66% of the internal forces in the lungs, while the connective tissue or just stuff like elastin and fibrin contributes to 1/3. Yep, I will be uploading these slides immediately afterwards. A lot of these slides are also based on my PSP, which are already up. But yeah. Yep, sorry. So talking about surfactant. So surfactant is this phospholipidy kind of oily compound which is released by type 2 pneumocytes. Type 1 pneumocytes are just your alveoli kind of composing cells, really flat, don't really do much, are site of exchange. But your type 2 pneumocytes produce surfactant. And what they do is increase lung compliance. So what does lung compliance really mean? It's really, if you did physics, then it might help you a bit. But lung compliance broadly means that how willing is it to adjust to the changes in its environment? Or what I mean to say by that is, if I try to exert an outward force pulling the lung or trying to open up the lung, how likely is it to open? Okay. So by increasing the lung compliance, you're kind of making it easier to breathe because it opens with lesser kind of pressure difference. And it also stabilizes the alveoli because without surfactant, your alveoli would collapse on themselves whenever you would exhale, which is obviously something we don't want. Lung compliance, as I talked about, tendency of lung volumes to change as the pulmonary pressures change. And it depends on a bunch of things. So surface tension and surfactant, and obviously elasticity. So all these three properties are what determine how compliant the lung is. And you could also know that there is the highest resistance to airflow in the medium-sized bronchi. I know you guys would have seen that graph where it talks about the size of the bronchi as they keep bifurcating and also the relative resistance. And the resistance is highest in the medium-sized bronchi. Surfactant produced by phospholipids and calcium, it's secreted in gestation. So premature babies can often have stiff lungs if they haven't produced enough surfactant yet. In these cases, they're often injected with high doses of oxytocin to produce that surfactant, but that's not really important for you guys. Yep, and just know that it helps to keep the lungs open. Difference in pulmonary ventilation. So if you look at the lung from bottom to top, either left or the right, you should know that they aren't ventilated equally throughout. So some alveoli, whether at the top or at the bottom, receive more ventilation than the others. Well, how can you figure this out? A really easy way to think about this is, you know that the lung is a big spongy tissue. Think of it as a slinky, yeah? So if you hold it from the top and stretch it down, the rings at the very top are likely to stretch the most. Why? Because they have the effect of gravity the most on them. So they stretch up and they open up quite a bit. Same thing goes with the alveoli. So with your alveoli, you tend to have your alveoli at the very top, which are nice and open. However, just bear with me for a second. So although the alveoli at the top are open, they're always open. Okay, so you can't really have a lot of ventilation going on there. Yes, you might have a lot of dead space and a lot of air trapped there, but you actually tend to have quite low levels of ventilation in these upper alveoli. On the bottom, however, because they're still quite tightly coiled up, they can expand quite a bit when you do actually ventilate them. Okay, does that make sense? Cool. And again, just talking about pulmonary perfusion. So very similar to pulmonary ventilation, because of gravity, blood tends to pool more at the bottom than it does at the top. This just means that the degree of perfusion to the lower lobes of the lung tends to always be greater than that of the upper lobes. It kind of makes sense because the areas where you are having more ventilation are the areas where you'd want more perfusion. So it kind of makes sense. You also need to know that because there's a large level of air trapped in the alveoli towards the apex of the lungs, you are more likely to have infections by aerobic bacteria like strep and staph in the upper lobes of the lung. Why? Because, well, these bacteria need air and need oxygen. And just those nice open lungs with tons of dead space is a wonderful site for that. So pneumonias and also secondary tuberculosis. Ventilation perfusion matching. So this is very broadly speaking, what do we do when your lung goes kind of, oh shit? So if either ventilation or perfusion are disturbed, locally, your lung has a bunch of mechanisms that it can kind of kickstart to accommodate for those differences. Now, you need to know, firstly, before we even talk about how any of this happens, that this is only for local issues. Okay, if I would say that a person goes up to climb a really high mountain, and as a result doesn't have adequate ventilation, this does not apply because this is only for localized segments of the lung. This would apply for stuff like acute airway obstruction, where a particular bronchus might be obstructed, or stuff like a pulmonary embolism, where your perfusion is impacted. Okay. Here's a diagram which represents that very broadly. So basically, what happens if you have a reduced blood flow to a certain part? So decreased blood flow, you would have a reduce in the PCO2 levels, in the alveoli, constriction of the bronchioles, and decreased airflow. Okay, so just know that however one changes, your lung changes in the exact same direction. So if you cut off ventilation to a certain bit of your lung would also cut off perfusion to that bit of the lung. Although this might seem counterintuitive and you'd think that the lung would try to kind of send in more support to that part since it's damaged, you need to think about the lung acting in a kind of survival mode pattern, and it just needs to sustain itself. So it would much rather send blood and air elsewhere where it can actually be perfused and ventilated well than actually wasted on that dead space. Is this a concept of hypoxic hypoconstriction? Someone's asked. Yes, so hypoxic vasoconstriction is something you'd expect as a local mechanism. It's kind of counterintuitive as you think about it. If you have hypoxia, why would you want vasoconstriction? But it's just again talking about how it's only for a local area instead of a globalized area. If someone would have global hypoxia because of something like the atmospheric air they're breathing in, then you would expect vasodilation and not constriction. Spirometry. So spirometry is pretty easy. There's not much to do here, to be honest. You just need to know these volumes and what they're composed of. So just very briefly going through that, going up and down here is just your normal breathing. And this would be your tidal volume, okay? If you then take a huge breath in, this would be your inspiratory capacity, everything from your your breath out to your deep breath in. The extra amount of air you could take in would be your inspiratory reserve volume. And then once you exhale that, that would be your expiratory volume. Anything extra, this bit here is your expiratory reserve volume. The bit you can never exhale out would be your residual volume, and that's just air which is always present in your lungs. And this entire thing would be your vital capacity. So if you take a deep breath in and then exhale as much air as you can, that would be your vital capacity, and your total lung capacity is all of it. You need to know that you can't just find out your total lung capacity on very basic spirometry where you talk about FEV1 and FVC. So let's talk a bit about FEV1/FVC. So the way this test is done is you take vital capacity, this bit, okay? So if you think, well, what's happening here, take a huge breath in and then blow it all out, and it's forced. Cool? Okay. So forced expiratory volume, FEV1, just means it's your forced expiratory volume in 1 second. So it's how much air you could get out in the first second of expiration, and your FVC is the total amount of air that you're able to force out on expiration. And we always look at the ratio between the two. Normally it's about 70 to 80, but it changes. In obstructive, it goes down. In restrictive, it's either normal or might go up. So our first step is to look at the FEV1 to FEV1 to FVC ratio. If it's reduced, bad, it's obstructive. If it's normal, well, it might be restrictive, it might be normal, you don't really know. That's when you look at the next step. You look at the FEV1 and the FVC. Now, the FEV1 is quite shit as a test because it can go down, it can go up, you can have an asthma attack, the temperature might not be right, you might have an infection, you can't really tell much. The FVC is much better to look at. It is always normal or very slightly decreased in an obstructive pattern. This could be something like asthma or COPD. However, it's always reduced in restrictive. So if your FVC is severely reduced and your FEV1 is normal and the ratio is normal, then you can say that that's a restrictive pattern. Examples: asthma, COPD. Sorry, I'm still very sleepy. Asthma, COPD. The difference being that asthma is reversible with an inhaler. You normally use a SABA or a short-acting beta agonist, while COPD is not reversible. In order to classify something as asthma, you need to observe a bronchodilator response of at least 12% and or 200 ml of air. Okay, with restricted stuff, it's stuff like fibrosis, TB, and also stuff like scoliosis, kyphosis, etc. Pressures in the thoracic cavity, we've already talked about this. This is just a summary slide, nothing new here. Okay, so let's move on to this next question on the oxygen hemoglobin dissociation curve, which everyone seems to hate. So which of the following would cause a right shift? Or as a broader answer, do you guys know what the oxygen hemoglobin dissociation curve is, and can you explain it to me? I think that's a good starting point. Feel free to say no. I would not expect you guys to know much about this. Yes, no. Okay, cool. I've got some answers. The two main ones being A and B. So I'll broadly explain this because I think this is important for exams and for future years as well. So this is the oxygen hemoglobin dissociation curve, okay? We basically look at the partial pressure of oxygen, which usually goes up to 100, and then what percent of hemoglobin has oxygen bound to it, okay? This obviously also goes to 100%. A few key takeaway points from this is, let's look at what's actually going on here, okay? So a few takeaway points. Hemoglobin saturates really easily, okay? At higher, as you can see, it's 90% saturated at 70 mmHg of oxygen, and it really doesn't increase as much if we keep increasing it, okay? It kind of plateaus here. That's point number one. Point number two, once you move below that 60, 50%, it kind of starts dropping really quickly. That's point number two. And I want you to think of this as two broad areas. So everything above 60, think of it as your alveoli, okay? That's when your blood is in your alveoli, that's when it's being perfused, okay? Anything below that is in your tissues. That's when hemoglobin is actually carrying the oxygen to your tissues for aerobic respiration. Two differences. One, in one case, it plateaus and is really good at retaining oxygen. In the other case, it's really shit at retaining oxygen. Although this might sound bad, you need to realize that the role of hemoglobin is as a transporter, and a transporter picks stuff up and then drops it off later. Okay, so although it's really good at picking stuff up at the alveoli, as it should, it's also really good at dropping it off when the pressure of oxygen drops, which is at your tissues, which is also good. Okay. Now, so once you have that down, you need to know what left and right shift actually means. Okay. Because once you do it, the rest is really easy. So the left shift just basically means that you have a similar level of oxygen saturation, but at a lower partial pressure. Okay. What does this mean? It means that your oxygen is favoring that your hemoglobin is favoring oxygen. It's binding better to oxygen than it previously was. While a right shift means that it's binding worse off than it usually does. Okay. Now, once you think about that, you again think of where you'd want it to bind better. So left shift is often observed in the alveoli, while right shift is often observed in the tissue. Okay, because that's where you want hemoglobin to start dropping off oxygen, which is good because you have reduced affinity and you have an increased affinity in the left shift. And the remaining stuff just explains what happens at each site. So starting off at the alveoli, it's colder. It has decreased hydronium ions, so it's more basic. It has decreased levels of 2,3-DPG, which is a chemical produced by our muscles when they undergo aerobic respiration, and also carbon monoxide poisoning. So someone asked me to briefly explain carbon monoxide poisoning. It's really easy. You should know that hemoglobin binds much, much more preferably to carbon dioxide than does to carbon monoxide than it does to anything else. It forms this unique compound called carboxyhemoglobin. And once it binds to carbon monoxide, it kind of forgets everything about oxygen, and you can very easily die of carbon monoxide poisoning. As far as redshift is concerned, it's stuff happening in your peripheries or in your muscles. If you think about it, increased temperature. Yes, if you're working out, you have increased temperature in your muscles. You're producing lactic acid, so your surroundings are more acidic. You have increased levels of 2,3-DPG because it's again a byproduct of aerobic respiration in your muscles. Okay, so the answer is 2 or B. Why does carbon monoxide increase oxygen affinity in that case? Sure. So in this case, you need to think about it as a global thing. So at very low levels, if you have a slight bit of carbon monoxide being bound to your hemoglobin tries to overcompensate this by having a greater affinity of binding. So you need to realize the difference between like an affinity and an absolute thing. So affinity just means what percent of the available sites are being bound. So just as a ballpark figure, let's say 90% of the available spots on the hemoglobin train were binding oxygen previously. Okay, let's say there are 100 spots on this hypothetical train. The 90% is just the percentage of the available spots. Now, let's say if carbon monoxide were to come in and take up 50 of those spots, you would only be left with 50 available positions on the hemoglobin molecule. And maybe those 50 would now bind oxygen to, let's say, 95% of their surface area. While although you technically have seen an increased affinity, you still tend to have reduced levels of oxygen transport. So although you have an increased affinity, it's still overall bad for you. Okay. Gas transport, I've already talked about this. Just know that carbon monoxide has 200 times the affinity that oxygen has, and it causes decreased oxygen carrying capacity. Cool. Asthma is a chronic disease and is an important cause of both mortality and morbidity, which of the following is the single most useful measure of the extent of the problem in the community? I know this isn't really a rep kind of question, but just I know that they'd love to repeat that question. So if something like this were to come up, which one would you guys put down as the answer? Okay, so surprisingly, I've got three different answers for this one. So I've got A, B, and E. Um, I recommend you look at the question once again. So, useful measure of extent of the problem. So this is talking about chronically how much does it impact the community. Um, the instance of new cases, well, you might have a high incidence, but that might not really affect how it affects the community long term. So the answer here would be B. Um, because you want to know what percentage of the population is actually affected by this, which goes in line with extent of the problem. Clinical signs of asthma may include which of the following? This should be really easy. Also, can people please send in stuff? Because I would hate to go with something that you guys don't really know and just assume that you guys know it. Yeah, so all of you got that one right. Expiratory wheeze. So that's one of the really typical signs of asthma. Dull percussion notes, consolidation slash pneumonia, crackles, pneumonia, inspiratory wheeze is called stridor. That's it. That's got you there. And is not associated with asthma. It can be associated with stuff like laryngeotracheal bronchitis in children or croup, and it's a really severe sign. So if you see it, that's a bad problem. Asthma versus COPD, you can usually diagnose this on spirometry. It's an obstructive pattern, which we've already established, and you differentiate it from COPD, which is the only other possible, usually obstructive condition, by testing for a SABA response. If it does respond to a SABA, great, it's asthma. If it doesn't, it's also COPD. It also seems kind of dumb, but usually if you have a patient and you would know whether this person has asthma or COPD. Is it a 10-year-old child or is it a smoker of 50 years? You know? And just for your reference, these are the flow loops in case they throw one at you. These are the only two ones they use in exams. This is obstructive, this is restrictive. Makes sense. FVC is reduced in this, and this one's just kind of dented in. Cool. TLCO, DLCO, it's just this test used to see how much of oxygen or how much of substance in your alveoli are being taken in into your bloodstream. This is done using stuff like carbon monoxide, very low concentrations of that though, just 0.3% carbon monoxide. And it just tests how much of it actually went into your bloodstream. It tests for alveolar conditions, stuff like emphysema and so on. Emphysema, smoking, fibrosis, and it should be normal in asthma because asthma is a bronchiolar disease, not an alveolar disease. Cool. A patient presented with making great time with sudden shortness of breath. The radial pulse was rapid and irregular. Investigations revealed a large thromboembolus lodged in the left pulmonary artery. The most likely source of this clot is from which of the following chambers of the heart? So this person has had what condition? What has this person had? So what do you call a thromboembolus in the left pulmonary artery? What's this condition? Yeah, it's a PE. Yeah, perfect. So where would this clot have come from? Cool. So we're getting a few answers here. Um, let's just work our way through that, okay? The hint here is that the radial pulse was rapid and irregular. This means that this person is in atrial fibrillation. AFib is a huge risk factor for PEs. And if you think about it, atrial means one the atria. Is it the right or the left? Well, think about it. If they're so because it's not contracting really well, blood tends to just stay there and form a clot. This clot then goes down to whichever lung it eventually supplies, right? So a clot in the left atrium, because it would go to the aorta, is more likely to cause systemic clots. So stuff like ischemic bowel and so on are more likely to be from the left atrium. But if it's in the lungs, it's most likely to be the right atrium. Okay. Some put down left pulmonary vein. Um, Unlikely, because it's very unlikely that a thromboembolus would be formed inside the vein. Yep. Oh no. Frick. On examination, the GP noted that Susan had creps in both lung bases and bilateral ankle edema. What's the most likely finding on her chest X-ray? So this person's heart failure. Okay, is it right or left? Because I already saw the answer to that. This one doesn't count. The answer is D. So what this basically means is that there is a backflow being caused, and it seems to be kind of a global pattern. It's a congestive cardiac failure because you have crepitations in the lungs as well as ankle edema. Okay. Um, this just means that there is more fluid than there should be in the lungs, which is very typical of congestive cardiac failure. It is also what causes your orthopnea, paroxysmal nocturnal dyspnea, and the only one associated with fluids in the lung is interstitial edema. Tracheal deviation, pneumothorax, collapse of both lung bases is called atelectasis, not associated here. Widening of the mediastinum often might be in cases of some tumors / aortic dissections. Decreased cardiothoracic ratio, don't really know what that is or what causes it, but interstitial edema, definitely. On auscultation of a person's chest, you hear a wheeze. Why do people get wheezes in the first place? Someone just asked, what's the cardiothoracic ratio? So just on X-ray, what percent of the width of the entire thorax is occupied by the heart itself? In cases of congestive cardiac failure, you often have left ventricular hypertrophy, which causes the heart to balloon up. So you tend to have an increased, not a decreased cardiothoracic ratio. And yes, the answer here is A. The bronchioles have narrowed. Very typical of asthma / COPD, and it's a bronchial problem. Cool. A 12-year-old boy whose family recently migrated to Australia as refugee parents present with 1 week of rhinorrhea, which is just runny nose, cough, and sinus congestion. He has no other past medical histories and no allergies. Otoscopy reveals a bulging erythematous tympanic membrane. Based on history and examination findings, the child is diagnosed with otitis media. What is your treatment of choice? So which one of the following antibiotics would you prescribe for this patient? Either send in an answer or just say that you know this / don't know this / this wasn't covered, or just random question marks. Yeah. Can't remember, don't know. Cool, perfect. So now I'll probably tailor a few more questions for this specifically. So the answer is amoxicillin, okay? The reason it's amoxicillin is because otitis media is treated with amoxicillin. In saying that, I realize it's a dumb way to explain this. But as you progress more, you know that vancomycin can only be injected IV. Doxycycline would not be used, neither would Keflacor. The reason we use amoxicillin in this case is because otitis media, or inflammation of the middle part of the ear, can often cause a lot of severe side effects. It obviously is not purely allergic. It's not viral, because you can see that there's a bulging erythematous tympanic membrane. And otitis media is very commonly caused by bacteria. Um, Also hints is that he's had a rhinorrhea, cough, and sinus congestion, so upper respiratory tract infection kind of signs, which is now complicated by otitis media. And your go-to drug for otitis media is amoxicillin. Okay. I'll talk a bit about infections and the drugs we use to treat them in a bit. Okay, so this is a question format you all should get very used to. EMQs, all of third year is only EMQs. Okay, so which one of the following is your diagnosis? Either an option or you just don't know. So I can discuss that. Jim Anderson, previously healthy 70-year-old retired male mechanic, presents with shortness of breath on exertion and chest pain. He's also had 2 separate episodes of syncope that occurred last week, and he's otherwise well. What does he have? Yes, no, no idea. Okay, so a bit of a mixed bag here. The answer is actually aortic stenosis, and I'll talk about why. This person is previously healthy. He feels otherwise well. Okay, he doesn't have any signs of congestive cardiac failure or acute sharp pain associated with an AMI. He's had 2 syncopal episodes. Syncope just means when there isn't enough blood flow going to your brain. Okay, that can happen with aortic stenosis because if your aortic valve is kind of stenosed or kind of more tight or calcified, not enough blood can actually go through it, which means you are more likely to have episodes of syncope. And he also has had shortness of breath on exertion, chest pain while walking up flights of stairs, um, and that all just ties in with kind of insufficiency secondary to aortic stenosis. Okay. Liz Baker is a 20-year-old, previously healthy female physical education teacher who presented the GP with a sudden attack of shortness of breath, palpitations, dizziness while she was checking her email in the evening. And the attack was about 3 minutes. What does Liz Baker have? Yes, no, no clue. Okay. Some people have, most people have said J, and a few people have said E as well. So the answer is J. This is a very typical panic attack. Um, the reason it's not asthma is that although you might have shortness of breath with asthma, you would not have palpitations, you would not have dizziness, and you'd have more stuff like a wheeze. It's very unlikely that an asthma attack would be brought on while someone's checking their emails as well. Okay. 45-year-old male presents to ED with shortness of breath and he had surgery a week ago. This should be fairly straightforward. This is very buzzwordy for what? H, perfect. This person has had a PE because he has had surgery, which is a huge risk factor for PE, and it's chest pain worse on inspiration, which is pleuritic chest pain again, PE. 26-year-old male presents to the GP with a non-productive cough, chest tightness, and shortness of breath on exertion. No known triggers, and he has a family history of hypertension, type 1 diabetes. What does this young man have? Any ideas? Yeah, so very good. So this is very typical of asthma, your typical non-productive cough, non-productive cough, chest tightness, shortness of breath on exertion. Okay. The reason it's not something like cor pulmonale is just because he's 26-year-old. You would not expect him to have portal pulmonary hypertension at 26. Someone's asked, is there a reason to mention that he has a family history of hypertension and type 1 diabetes mellitus? Not really. Asthma is more associated with your atopy, so your asthma, eczema, and allergic rhinitis. But just knowing that something that is autoimmune slash hypersensitive could lead you to asthma, but I wouldn't count too much on that. Moving on, 76-year-old male with a 30-pack-year history of smoking presents to the GP with worsening shortness of breath. There is ascites, pedal edema, and the JVP is raised. So ascites, pedal edema, and raised JVP. So this is a bit of heart failure stuff, right? But before you answer the question, is this left heart failure or right heart failure? So just think as what things lead to that. Ascites, blood comes in from your gut into your right side heart. Ankle edema, right side heart. Increased JVP, right side heart. So this is right-sided heart failure, okay? You should always know that anyone who presents with purely right-sided heart failure has something else going on. Heart failure or congestive cardiac failure, the very typical one, doesn't present purely with right-sided heart failure. It's mostly, there's a lot of lung involvement as well. Because he has a history of smoking, you would think that there is a respiratory cause to this. So this person actually has cor pulmonale. Oops. And what cor pulmonale is just increased kind of fibrosis and increased resistance in the pulmonary circulation, which causes blood to back up and then eventually cause a whole bunch of right heart symptoms. Okay. 42-year-old presents with productive cough, chest tightness, and fever. Lungs sounds are distinct and clear with crackles at the left base. What does this woman have? Productive cough, chest tightness, and fever. Perfect. You all got that. So this woman has pneumonia. Oops. Yeah, so she has pneumonia. So chest tightness, fever, productive cough. This would just be a normal case of community-acquired pneumonia. She probably just has a strep pneumonia. You were treated by amoxicillin. If required, probably would not require hospital admission. Okay. 34-year-old man presents to the primary care setting with 7-week history of hemoptysis. He has had a poor appetite. He's had a bit of loss of weight. He feels febrile at times, but has not measured his temp. He doesn't have any shortness of breath, and he's originally from the Philippines. What does this man have? Perfect. This man has TB, right? The reason it's not something like lung cancer, which is the only other differential for this, is because A, he's fairly young. B, he has a bit of a temp. You don't really have a temp with cancers. He's originally from the Philippines, and Monash just loves to chuck in every Southeast Asian person ever who he has TB. Okay, it's just something you need to know. Cool. 69-year-old female presents with a cough and shortness of breath lasting 2 weeks. Her sputum is pink and frothy. So pink frothy sputum is very typical of one condition. Yep, most of you got that one right. The answer is pulmonary edema. It's because when stuff moves into the pulmonary space in the alveoli, sometimes blood and a few RBCs do as well, which is why you get the pink frothy sputum. Okay. Those are for the questions. Here is a two-page summary of all the kind of clinical conditions that you're expected to know, what a typical presentation is, what you'd see on an exam, how you'd manage them, like basically everything you need to know condition-wise, in case you want to go back and have a look at this. So just two cases here. Some of these are more important than others, but I think just going through this once would be really helpful for you guys. I won't cover this right now. A reliever medication used to treat asthma only is which one of the following? Yep, perfect. So the answer is a SABA. Ali is a 50-year-old man who has hypertension. He's been put on a certain medication and now has a dry cough. Which one does he have? I think this is pretty straightforward. He has an ACE inhibitor-induced cough, in which case you'd put him on a sartan. And here's your very brief medication table. You should know your broad for your SABA, LABA, SAMA, LAMA, yes, and also your ICSs. You should know the stepwise approach to asthma and COPD. Those are two conditions that say you should do the pharmacology of quite well. As far as microbiology is concerned, I know no one really cares about this. And most of the stuff is often easy and giveawayish on exams. But I have a few important points I'd like to talk about for like the next 2 minutes. General concepts. So most infections are both upper respiratory tract and lower are viral. Okay, so in most cases, you would not be treating the underlying cause, you would mostly be managing the symptoms. So stuff like managing a fever, shortness of breath, just give them oxygen and so on. Okay, if a viral case is severe, like influenza, you would treat them with antiviral therapy like cyclovir. Okay, that's very broadly for viruses. Bacteria are bad. They mess stuff up. You treat them with antibiotics and you manage their complications. So with a lot of bacterial infections, you can have a nasty range of complications in other parts, which you might not expect. So you need to manage that as well. Here's another table with all the various sites of infection, what the features are, and also a few complications. For example, you need to know that acute otitis media is often with a viral upper respiratory tract infection in children, as we saw, and usually self-limiting, treated with amoxicillin when appropriate. Perfect. You need to know that otitis externa can often cause long-term hearing loss if not managed well, which is why you also provide corticosteroid therapy to reduce the levels of inflammation. Croup can often cause a biphasic stridor, in which case, again, you would use corticosteroids. Okay, you get the hang of it. So broadline antibiotics followed with steroids if you want to reduce the levels of inflammation. Okay. Influenza, again, is probably the only viral ones where you'd actually give an antiviral drug. And stuff like TB, you probably would have already done this, but you have the RIPE, the rifampicin isoniazid, pranizumab, and ethambutol. And it might just ask which one of the following medications is used to treat TB. Okay, that's all. I see you all not next week. I'll be coming in for the rest of these presentations as well. Feel free to ask me any questions. Probably, if you have any, you can message them to me on Messenger or something. I'll be more than happy to answer them. I personally might also host just a little exam revision thing later next week. But that's all from me for now. You have another wonderful lecture with Grace over on the other Zoom link, who'll be going through renal stuff. But yeah, see you guys there and hope this was a bit of help.